Good morning, good afternoon, good evening from wherever in the world you're dialing in. It's my great pleasure. I'm Steve Williams as the PI of the Unity Project, which is the Ultra Low Field Neuroimaging in the Young Project, which is funded by the Gates Foundation. And I'm based here at King's College London. And I'm going to be introducing to you today's seminar, which is all about real life case studies and expert insights from some of our cases, based with Hemant, is an he's an experimental neonatologist at Bonn, and our Hyperfine lead CMO, Eddie Knopp, who is going to be talking through 5 cases, and we look forward to your interaction and engagement in the Q&A on the side. So without further ado, I'll hand over to Hemant and Eddie, and Jess is going to make sure we all behave.
Thank you for the introduction, Steve. We have an exciting new platform to introduce today for this webinar, which has been developed by Collective Minds and is a new seminar feature that should hopefully make this more interactive and easier to follow for the attendees. But just to summarize how it will work is there will be 5 cases that have been kindly contributed by the team at Bonn University. So a huge thank you to all of them who've sent through information and scans for us to review. We're going to go through those one by one, and those are all here in the seminar. And as we go, there will be interactive sections where people can respond to a poll, and that will be anonymously that you can do that. As I said earlier, there are 5 cases. We've got Professor Beer, who's going to present the clinical information for each case, and then Dr. Knopp will do a review of the low field scan first. At that point, we'll be able to ask the group for their answers on a poll as to what the most likely diagnosis is. And then we'll have a look at the high field scan for that same participant and be able to do a comparison of the two. So you will see that format throughout the seminar, but Dr. Knopp will lead you through from case to case. So I hope everybody enjoys it, and we'll be keeping an eye on the chat if there are any questions along the way, but please do make use of the Q&A button, as Natalie said. All right, thanks everybody, and I'll hand over to you, Dr. Knopp.
Okay, thanks guys. So why don't we get started, with the first case. And Hemant, if you'd like to give us a little information.
Yes, good morning, good afternoon, good evening, wherever you are. I wanted to say thanks to Natalie and the team at Collective Minds and Jess for organizing this and putting this together. This is going to be great. So the first case we want to present to you is a 5-week-old boy that was presented in our outpatient or emergency department. He was born normal, he was discharged normal, so he was term. There was an uneventful pregnancy. He's the first boy. He had a normal adaptation. And when he was 5 weeks at home, the mother realized that he started to drink less. He was a bit lethargic. And she presented him by saying, or she called the ambulance by saying that he's moving strangely and he's grunting. So she didn't really know what to do. So he was then transferred to our pediatric emergency department. And while the ambulance was coming to the home, he realized, or the caretakers realized that the baby had a quite low Glasgow Coma scale. They intubated and then have taken him to our emergency department. Whilst he was then investigated here, so he was stabilized, he was brought on intensive care. And what we realized immediately is that he had an abnormal AEEG, so amplitude integrated EEG, as well as an abnormal or pathological EEG with suspected seizures. And we also then realized that he had retinal bleeds bilaterally, and also he had fractures on his bones, especially his tibia and his fibula. On his clinical course, we were alerted, of course, because he didn't respond well to his seizure medication. So he was treated with phenobarb and phenytoin. And so, of course, we did an ultrasound and also then quickly performed an ultra low field scan. And so, Eddie, do you want to take us through the scan?
Sure. So let's start with the ultra low field hyperfine scan. So what we have is a series of images, basically standard imaging from the swoop scan. And we have the axial T2, the axial flare, which duplicated itself, so these are the same, coronal T2 and sagittal T2, and the axial standard diffusion with a B of 900, and that's unidirectional. I think the first thing to note, and what I like to look at when looking at them, is just to kind of, to use a US term, kind of gestalt it, get a sense of everything. And right off the bat, we see there's significant asymmetry in the scalp. And given this history, so now we're concerned about scalp soft tissue swelling, scalp edema, and we're alerting ourselves clearly to the setting of trauma. We already know the child has long bone fractures as well. So let me make this a little larger and window it a little better. So the axial T2 weighted image, this is a little better. We can see that there's extraaxial fluid space. We have this scalp presumptive hematoma. As we come more inferiorly, we're getting signal change in the inferior temporal lobe on the left. Looking at the flare, let me try to window this one. We're seeing the same thing, right? So we're seeing signal change in the brain parenchyma adjacent to, or subjacent to the bony calvarium. Hallmarks and findings that we typically see in the setting of contusional type trauma. Looking at the sagittal, again, we get a sense of the scalp soft tissue swelling. There is some irregularity. We can see that here. I think it's easier to see on the coronal. Again, so that inferior left temporal lobe and the diffusion. Weighted image is showing some evidence, it's a little difficult to see, of restricted diffusion. And realize there can be various causes for restricted diffusion. Classically, what everyone knows is acute ischemic infarct and cytotoxic edema, but realize that intraparenchymal hemorrhage can also restrict in diffusion. The clot has more water, and that water doesn't move as freely and normally as the remainder of the brain itself. Let's see if there are any other sequences we can look at. And here we have the coronal T1, which is very helpful in that we can see change, but we also see evidence of additional increased T1 signal consistent with hemorrhage surrounding that temporal lobe and coming down. So imaging characteristics are consistent with what we're suspecting in this child, in that there is intra as well as extracranial trauma in that setting. Hemant, is there anything you'd like to add?
No, so thank you very much. So for me, the question would be, is there any, so from these images, if we think this is suspicious to trauma or following trauma, is there, should I be concerned as a clinician of serious or severe edema and serious swelling? So is there something you can say about that?
Sure. So indications of swelling and mass effect tend to include some evidence of shift of normal structures in the brain parenchyma. What we've seen is most of our signal change is on the left, yet midline structures do not appear to be shifted. It's important from the sagittal imaging to look in the region of the foramen magnum, because significant increased supratentorial intracranial pressure may lead to what's called herniation, where the cerebellar tonsils extend through the foramen magnum and down, a very ominous sign, and I don't see evidence of that either.
Okay, thanks.
Okay, so I think there are some questions, and let me click questions. And basically, the questions for all the cases are going to be the same. What's the most likely diagnosis? Realize you can select more than one. And then once we look at that, once you select the choices, we can see the results and then move on to the next portion of the case. I guess this is
For
telling
all
me how many.
the attendees, you'll need to open your delegate link to answer the question. So just if you have that in another tab or on a separate screen, you'll access the questions there and you can send in your responses. can see 4 people have responded so far, so we'll give you a little bit more time.
Well, in the interest of time, why don't we take a look at the results? And what we see is evidenced here. So the majority of everyone thought clearly there was intraparenchymal hemorrhage. And I think that was well demonstrated. There's also a suggestion of sinus venous thrombosis. And then a couple people were thinking hemorrhagic stroke. And I'll see what Hemant's thoughts are. From my interpretation of hemorrhagic stroke, I'm thinking more about acute ischemic infarct, which has bled into it. So that's the primary etiology, as opposed to intraparenchymal hemorrhage itself. Hemant, do you have any thoughts about that?
No, I mean, there's both etiologies. So it might be, a hemorrhagic infarct or infarction after an ischemic stroke, but there also might be a primary hemorrhagic stroke, which is, of course, much
So then a
less
hemorrhage
often
that we're
in
calling
neonatal
stroke as opposed to infarct.
Yeah.
Okay, so why don't we move on? So now this is the 3T scan. Any comments before we kind of go through this, Hemant?
No, I think it's just, now to see so my primary question would be, of course, what we see on low field, is it a true finding? Is there any correspondence on our standard imaging? And then, of course, the question, do you see any additional things that we've missed on low field? Because then, it would lead us to the question, can we trust the low field? And is it probably enough for neuroimaging in this child?
Right. So here we have the axial T2 in this case, again, starting from the skull base and coming up. And again, we see this similar area in my mind of T2 signal abnormality in the brain parenchyma. If we look at the coronal, it outlines it to, gives us a little increased conspicuity. I'm looking for, we have the T1 sagittal here. Let me make it a little bigger. And this looks like a Gatto T1 sagittal, but nonetheless, we see the extensive signal change. It's tougher to see on this post-contrast T1. I'm going to see if there's a pre. Because the extraaxial collection is a little confusing from that. Here's pre-contrast T1. Obviously, the left inferior temporal lobe signal change. Interestingly, the conspicuity of the extraaxial blood is not as clear on this, but I think this preceded the original study. So at least in my mind, from a neuroradiologic standpoint, to answer the acute clinical question, the hyperfine provided similar information, as did the high field, albeit the high field had, obviously a significant increased resolution. Hemant, anything to add?
Oh, thanks. And this is exactly the thing, that would be, for me as an emergency clinician and being an intensivist, the question is, do I need all this additional information, just that it looks much more clear, or in a way, that the resolution is much better, but I see the pathology on low field. I see kind of that there's no increased intracranial pressure. And yeah, I mean, we would be very interested to see what you think. So do you think that the ultra low field MRI was sufficient? We've put this as a question into the question section up on the right. So I would be interested to know, Eddie, if you would be the radiologist on call in this case, and you would just have the low field, what would you think now knowing both images?
I would think that I could make the diagnosis, albeit not a pleasant one, that the child has intracranial and extracranial trauma with intraparenchymal hemorrhage, contusions, extraaxial collections, all just from the swoop image. And I think that depending on his clinical state, the high field, in my mind, I would not recommend a high field follow-up.
Yeah, exactly. And that's what we thought here. Of course, we did the 3T, but we did follow up low field images, which is, of course, then the big benefit that we have, that we can do serial imaging and say, okay, let's look after an hour, after 2 hours, after 5 hours, after 10 hours, or whenever anything changes clinically, then you can also, with minimum amount of work, rescan compared to if you would like to rescan on 3T.
Clearly the advantage of the portable MR. And I think everyone is in agreement that the hyperfine swoop scan clearly answered the question, provided all the necessary clinical information for prognosticating and treating the child.
Good. And there's one question I think in the F&A section by Jamil, who asked if this is hemorrhagic trauma.
So from a radiologic standpoint, given everything we've seen on the image, the evidence of location of this hemorrhage at the interface of the brain and the inferior skull, it's clearly consistent with the contusion in my mind. In addition, we saw scalp soft tissue swelling that looked like it was in the opposite location. So now we're dealing with what we call coup and contra coup injuries. In my mind, this is absolutely positively consistent with traumatic contusion.
Good, great, thanks. So if there's any other question, please put it in the chat. And if not, then I think we could
Go on to the next.
Yeah, go to the next case. Or do you have any more questions or comments to me as a, as the treating clinician, that you would give me, Eddie, for this case?
I don't think so. I think, the scanner performed and answered the question to the extent that it could.
Cool.
I don't think it was a pleasant outcome, but nonetheless,
Yeah.
Child could be treated accordingly. So why don't we move on to the second case?
Yeah. Second case is a child that is 4 years old. It's a male boy. And so he had been in the hospital for quite a while. He has a history of congenital heart disease. He was born with an unbalanced, what we call atrioventricular septal defect. He had a transposition of the great arteries, and what we have seen in him is that he had pulmonal valve atresia, not only stenosis. And there was a blunt part where recently, the valve should have been. And what we found that he had a thrombus in the blunt after some of his procedures that he had undergone through in his first years of life. So, but he was on a balanced side. He was, of course, he was a cardiac patient, but he was fine. He was home. And he woke up in the night and he was unable to talk. And the parents first, because, he had never had that before, and he was in a stable condition and they weren't so alerted. So they thought that he had these, what we call as pediatricians, night terrors, that he wakes up whilst dreaming badly. But then the next morning, he was also unable to move his right side of the body, and they took him to the emergency department of our outpatient clinic. And what we then saw here on the neurological examination were some, alerting signs for something that was going on in his brain, probably because he had facial paresis on the right side. He was really unable to move his right arm and leg. They were flexed. And he had a positive Babinski sign, which as a neonatologist wouldn't be probably something that I would be alerted, but with 4 years I would. So he was then taken to the 3T first, and they performed a thrombectomy because they found that he had a thrombus in his blunt, as I said, of the pulmonary valve atresia. And then we followed it up on ultra low field because we wanted to see what his pathology was. And I would be interested to see, Eddie, if you are here, your thoughts on the imaging that we've performed.
Okay, so let's look at the imaging. Just even before doing that, from a radiology standpoint, what's critical to us and to me is getting appropriate clinical information. It kind of focuses what I'm thinking about before even looking at the images. Clearly, this is pointing to acute ischemic infarct, right-sided physical exam, left-sided brain. So let's take a look and let's see what the swoop is showing us. So here we have axial T2 of the child's brain coming right off the bat. And again, in my mind, looking at these, we always look for symmetry to try to make determinations. And right off the bat, we see in the region of central sulcus, posterior frontal, anterior parietal lobe, it looks like there's increased T2 signal related to the cortical surface in this gyrus. Doesn't quite look normal. In addition, we see this signal change in the region of the basal ganglia, internal capsule. Whoops. There's some dark signal as well as some brighter signal. The sagittal shows the same change. It's a little difficult to kind of see, but also in the last point, the foramen magnum is patent, so there's no significant herniation of any sort. Coronal imaging shows us the same thing, but now we see that this cortical signal abnormality with mass effect, we're not really seeing the sulci, is somewhat more extensive with this additional signal change within the deep basal ganglionic region. If we look at the T1 weighted image, and this is a gray-white T1, kind of accentuates these signal changes, we see that there's signal drop consistent with the edema and this kind of iso-intensity that was darker on the T2, suggesting to me that maybe there's hemorrhage and blood product here. Of course, given our history, what we're concerned about is acute ischemia and on the diffusion. And this is, for those of you that have the swoop scan, this is your normal standard diffusion weighted image. It's a DWI with a B value of 900. We can see there are multiple foci of restricted diffusion here in what we call the peri-Rolandic region, accounting for his right hemiparesis. This is on the left side of the brain. And then we have this area of diffusion abnormality as well in that deep area that may be hemorrhage in my mind. In addition, Professor Sabir has the ability and has some fancier sequences, and this is what we call a trace image. This diffusion sequence is more analogous to what we see at Highfield. It's coming down the road in new software updates, but it gives us a cleaner image when we compare side by side the two images, showing basically the same thing, but in my mind, it increases our diagnostic confidence. And what we're now dealing with, in my mind, is acute ischemia. And in this instance, I believe that there's been hemorrhage within the basal ganglionic region. So anything to add, Hemant, before we go to the questions?
No, so thanks, Eddie. One thing is, if you looking at the lower right image now on the occipital part, it also appears to me like, there's some change or high diffusivity. Could you probably comment on that as well?
Sure. So what we note, and it becomes important in positioning, especially children, in the hyperfine scanner, proximity to the head coil itself can cause increased signal abnormality. Here it appears to be more manifest on the unidirectional diffusion than on the multidirectional diffusion. I think this has to do with that the head is resting on the coil surface and not on a pad to separate it out. So in my mind, that's artifactual and not pathologic.
Thank you very much, because this is, I think, very important because we see this often in quite a lot of cases. In the beginning, we were alerted, especially when we didn't know the clinical scenario so well. And, the patient was intubated and we didn't know how he was performing. And then we found out by the time, as you say, that this is not a pathology that we can see here. Okay. So, and then
let's go to the question.
And then the one question that I would also always have to you, of course, as a neuroradiologist, and especially in this case, as the last case probably still had an open fontanelle, and I wouldn't be so much alerted about intracranial pressure. But here, is there any signs of intracranial pressure? And again, could you probably say, what would I see?
So there's localized evidence, a kind of mass effect, as we're seeing some sulcal effacement where the infarct is. In addition, where what I believe is a parenchymal hemorrhage, there's mass effect and maybe a slight degree of shift of the midline structures, but nothing that would be significant. As we saw earlier, there's no evidence of tonsillar or tentorial herniation here. So I think if anything, it's probably minimal, if at all present.
Okay, thanks. And of course, then if I could rescan after 6 hours, 10 hours, 12 hours, 24, whatever, this is of course something that we would carefully look for if there's any signs of edema.
Right. Clearly, there could be more edema mass effect related to this, in which case then you would expect some midline shift so that the septum pellucidum here would be more over towards the right. indicative of prognostic increased mass effect, so you'd have to deal with that accordingly. So let's look at the questions. And again, most likely question, most likely diagnosis, intracranial bleeding, thrombosis, aneurysm, ischemic stroke, status epilepticus.
Just a reminder to anyone who is trying to access the questions, you'll need to click on your delegate link and then use the arrows at the bottom to get to this case, and then click on the questions tab and submit your answers.
Okay, let's take a look, see what we got. We have a combination of thrombosis, intracranial bleeding, with a slight majority saying ischemic stroke. So let's move on now to the 3T. Okay, and here we can take a look at the axial T1. And what we can see again is, again, somewhat subtle. That area of ischemia, the cortex is a little thickened. And again, this area of mass effect signal change, and I presume related to hemorrhage. If we look at, pull up the, I think the flare image is a nice image to show. And again, we see that there's evidence of signal abnormality, edema with some dark signal, and there's blood product here. And we can see the areas of ischemia, also with flare signal change. Find the diffusion. Might have been up on top. Yes. Let's put up the ADC. So on the ADC map, as we know, restricted diffusion, the water can't move freely. It gives us a bright signal on the DWI image. On the ADC, apparent diffusion coefficient, it's actually showing us if the water can move, we have signal. If it can't, it's restricted and we get dark signal. So we're seeing evidence of that acute ischemia here, as well as the signal change that we've seen both on the T2 and on the T1 in the basal ganglionic region. In my mind, it's confirming what we saw on the swoop scan itself. Hemant, anything to add before we jump to the next question to see if anyone thinks that this added anything or not?
No, thanks.
Okay. So could we make the diagnosis alone with the swoop and save all the hassle and trouble of taking the child down to the 3T MR or the 1.5, whatever you happen to have?
Eddie, can I ask you a bit of a loaded question?
Sure.
I thought that T1 on the hyperfine was actually had better conspicuity than the T1 at high field, or am I just being a little biased?
In terms of the overall imaging appearance?
I know in terms of the overall delineation of the pathology, because the T1s are sort of flatter at ultra low field, I just thought that it sort of came up and was more apparent, perhaps. I mean, definitely not less apparent anyway, put it that way.
No, definitely not less apparent. I don't,
Yes.
yeah. I think these images are beautiful. So it's going to be tough for me to argue otherwise. So looking at the results, again, 100%, everybody who's voting feels didn't need to take the child through, the high field itself. And what we had is thrombosis, which was seen on an angiography, acute ischemic stroke, and that intracranial hemorrhage as well. So I guess we can go on to the next case.
Okay. So this case probably shows the whole range or umbrella of patients that we're treating as pediatricians and neonatologists, because it's a 17-year-old boy, and I was on call when he came in. He was 110 kilos, so I don't know how much that is in pound or stones or whatever measure you take, but it's heavier than I am for sure. So
Big boy.
yes, so it's a big boy, and he was it was very funny when I asked him which class in school you go. He said, "I'm not going to school. I'm actually working." So he was he was out with friends drinking and smoking a bit, and they were partying a little bit, but not too heavily. He said there wasn't any history of drug abuse, and but when he came home after, like I said, a gaming night, as he called it. He had, severe headache, and also he started with strabismus. That's something that his mother then realized. And she then took him to a local hospital, and they looked at his eyes, and there was nothing obvious there that they could see, but they also thought he's a bit strange, and he had this massive headache, so they primarily thought he might develop meningitis. And so they performed a lumbar puncture, which was also quite normal. And he had normal ECG, he had normal EEG, but then as the night went on, he was transferred to us. He had right-sided hemiplegia, which was getting worse and worse. So he was then transferred after the initial image in the other hospital to our university hospital, and then also had a 3T and an ultra low field here in Bonn. So maybe we can look at the images.
Okay, so let's take a look. And here we have swoop images. And first thing just to note, there is some patient motion on some of the images. And also, in contrast to some of the other studies, he's not as positioned as high in the coil. This might be due to his body habitus, or since he's
Exactly.
somewhat large.
Yeah, no, it was exactly. I tried to put him into the machine, but it was, I mean, Steve has just said it's 242 pounds. So
Wow, that's big.
this is I had some problems to get him in. And also because he was not feeling well and he was having so much headache, it was hard to tell him to rest for like some minutes, because then he wanted to get out quite quickly again. It's sometimes much easier to handle babies.
At least you can handle them easily. So here we have axial T2, just looking at kind of generic. There is motion, so the image quality is not exactly the same. Getting to the question that seems to be consistent here, there is no midline shift, so there's no asymmetric significant mass effect pushing one aspect of his brain to another, and nothing quite really stands out. The sagittal T2 is also showing us basically the same thing. The inferior cerebellum and skull base is somewhat obscured due to the difficulty in positioning the child himself. T1 standard we have here, and this is kind of gray-white. It's the standard T1 with flat imaging contrast. And again, not much is standing out. This is due to positioning and is artifactual. The gray-white shows basically kind of similar findings in that there's maybe some vague signal change in the deep basal ganglia. Again, hard to tell on this image. So there's really nothing that's truly standing out in this setting. From a clinical neuroradiologic standpoint, if we're suspecting vasculitis or maybe meningitis, contrast enhancement, FLAIR imaging are exceedingly helpful because we can see pathologic enhancement of the leptomeninges, and FLAIR imaging signal change or abnormal signal in the CSF spaces that we're kind of not visualizing. There is something going on here, and I can't quite characterize it appropriately if we put the T2 up in the same area and come down. There is some vague signal change here, and maybe this is a sequela of some encephalitic process that's occurring in this portion of the brain, but I don't have sufficient information, I think, to truly further characterize this. Hemin, I don't know if you have any other thoughts?
No, thanks.
Okay, so let's take a look at the questions right now. So what's our most likely diagnosis? Again, this is the probably prominent finding seen on T2, as well as, we'll go back, and on this T1 weighted image, tumor, migraine, ischemic stroke, psychological disorder, or meningitis. And again, this one, not quite as obvious as the last two.
Well, I think the first two were just to warm up a bit, right?
Oh, okay, fair enough. And we have a potpourri of diagnoses. Again, just confirming the fact that maybe not too obvious. I think we're going to know that, sometimes things aren't quite as obvious and you need further assessment and evaluation, but obtaining something at the bedside in a child such as this or patient such as this, you can rule out certain major things, and maybe you do need additional information. So let's go on to the high field.
Yeah, and I think, what you just said, Eddie, is something that is absolutely important. I mean, what is obvious now from this image is I don't need to call the neurosurgeon now immediately at 3 o'clock in the morning and say, we've got a problem here. You have to help me immediately. And I think this is also something which is very important.
No, absolutely. You rule out all of that severe acute abnormality. So here on the high field, let's go back and put this here. Okay, so on the high field, we have axial T1s, and this child also received contrast. And the T1 is showing us with gray-white distinction. If we go back to that same area, it's a little asymmetric. There is some mass effect here. This is a diffusion-weighted image, and we can clearly see abnormal signal and restricted diffusion consistent with ischemic change of some sort. If we go to the post-contrast sagittal and come over to that area, and this is a volumetric, so these are thin slices, what we can see in that area is it looks like there's congestion and crowding of these sulcal spaces, and maybe there's suggestion of enhancement in here. So in my mind, I'm thinking that maybe there is a meningeal process, a leptomeningeal process with enhancement and subsequent ischemia in this setting. There's no flare again that was done. There's this T2. This looks like a gradient echo T2. So again, swelling in this region, no evidence of blood product. On the gradient echo T2 star image, we would see that as signal dropout, something that unfortunately at the present time, the swoop scan can't show us at a field strength of 64 millitesla. Anything else, Hemin, that you'd like to?
No, the question would, if you would go back to the low field, and look at the diffusion changes, now that we know kind of what we would expect, would you then, with the, as we would say, retrospectoscope, would you then see any changes?
I only see a B0.
Yeah,
I
okay.
don't see diffusion. So, and on the swoop, on the hyperfine scan, B0 doesn't really give us much information. On a high field scan, the B0 can show us some form of susceptibility weighting, but that doesn't exist on this scan. So I don't have a diffusion scan.
Yeah, and that is the thing that is, of course, then in this case, I had to take him out of the scanner just because this is why he was moving, because he was complaining, and he said it's too narrow for me, and my head, that's
Gotcha.
why I want to take him out.
What we're seeing on this B0 is basically a T2 flare type image. So we're seeing that signal change shine through the normal imaging. This is not restricted diffusion because we don't have any diffusion gradients that have been applied. So going back, this is the high field. We can ask the question, do we think in this case we had sufficient information from this swoop scan, or we needed high field? Realize, as Professor Samir just told us, the swoop scan really wasn't a complete study because he came out of the magnet before we would like to get necessary information. So I would have to agree. And the reason being that we didn't have a complete study. Had we had a complete study, maybe that would be a different story. And we
But
can
again, I mean, of course, then the beauty of, or the ease of it is, of course, that they can rescan him very quickly. Again, I've ruled out with a low field that there's anything that, I have to have immediate action from. So no signs of intracranial bleed, no trauma, no tumor, no extension of ventricles. So I could rescan after 12 hours, for example, right?
Right. Absolutely. So I think in the interest of time, maybe we just do one last case.
Yeah.
Do you have a preference, Hemin, as to what we should go to?
No, just the next case probably.
Okay.
No. Because it's again, something that we see quite often, a 4-year-old boy, no previous medical history. He presented with headache, basically. He had normal vital signs, normal neurological exam. And he was then, he had a 3T because they didn't find anything else, basically. And they said, okay, let's do neuroimaging. And the thing that was really what was the beauty here, that he did absolutely well, ultra low field without sedation. And you can look at the images and tell us what you think.
Okay, and I think that's a key point. One of the advantages because of, and I think most of you, if not all of you, have seen the swoop scan. Family members, caregivers can be with the child. It's not as,
Yeah.
scary
And
as
with
the high
him,
field.
yeah, and with him, I mean, he was watching a movie on the iPad that the mother held, whilst doing the scan.
Fantastic. Okay, so we have T2 weighted imaging in multiple planes, sagittal, axial, and coronal, and we can look through these. Again, these are fast T2 as they're indicated, but they're still, of diagnostic quality. And again, child didn't have to be sedated, didn't have to have anesthesia, didn't have to have basically anything, and is watching a movie during this examination. So looking through the brain images themselves, going from vertex down to the skull base, there's an area of signal abnormality within the right cerebellar hemisphere. It looks like there's some maybe edema and some signal dropout. You can see there's localized mass effect. Again, we always want to assess mass effect. In the supratentorial brain, we do that by looking at the effect of the septum pellucidum. Here, we can see the fourth ventricle. The fourth ventricle should be symmetric in its appearance and in the midline. And what I see is that the lateral margin of the fourth ventricle is being effaced. It's being pushed by the process that's occurring in the right cerebellar hemisphere. If we look at the sagittal, and as we come over, we can see again all this signal change within that portion of the cerebellar hemisphere. And there's area of signal dropout more posteriorly. The coronal image, he's starting to move here. Maybe the movie wasn't keeping his attention as much. Kind of shows us similar findings. There's a lot of signal dropout here. So it looks like we're dealing with, in my mind, a pathologic process in the right cerebellar hemisphere that is exerting mass effect, somewhat heterogeneous. Maybe there's calcification, maybe there's blood product. There clearly is edema. And all we have is T2 weighted imaging, so it becomes a little difficult to make definitive radiologic diagnosis from this.
And could this cause the headache?
I think any form of intracranial mass effect could cause headache. The signal change does extend to the superficial surface, and obviously the brain parenchyma doesn't have nerve endings to cause headache, but the meninges and coating surfaces, be it pia arachnoid, can do that. So I think headache could be caused by this.
Okay.
So let's take a look at the questions. So what's our most likely diagnosis? AVM, seizures, and I don't know how we make a radiologic diagnosis of seizure other than a lot of motion, migraine, intracranial hemorrhage, or meningitis. Interestingly, this keeps catching my eye, as does this. And people are a little more hesitant in answering. Let's get the last of the... My sense is we have a solid group of people who answer questions, and everybody else is sitting back and watching. Let's take a look at the results. And what we see, intracranial hemorrhage and cerebral arteriovenous malformation. And from looking at what limited information we have, we could have hemorrhage and AVM together, concomitant. I'm not quite sure what this is from signal dropout. This clearly could all be blood product, and clearly within my mind, within the spectrum of what's going on. Hemant, anything to add?
No.
Okay.
So,
There's a question in the chat from McLean who's asking what might have caused the ringing artifact in the T2 coronal.
I look at this and I see motion. And I think maybe he got bored of the movie or fell asleep. People always in a high field magnet, they say, oh, well, I fell asleep, it was okay. But people move while they're sleeping and they can't control that. So that's possible. I would think that that's what this is.
Yeah, that is, I mean, he was moving a little bit.
Right. But was able to tolerate the exam without sedation and able to watch a movie. And here we have the high field. So let's start right off the bat with the T2, make it a little bigger. Maybe, maybe not. Oh, here we go. So supratentorially, things look very symmetric, look very nice, young, healthy brain. And as we come down to the cerebellar hemisphere, we see multiple findings and that are critical and important. And that obviously there's signal change and mass effect. We can see what I saw was the effacement of that lateral fourth ventricle. But in addition, we see all of this black. And on T2, we know that these areas are signal voids due to flow voids due to increased flow. And the location of some of these is consistent with large arterial venous structures, or arterial structures, as well as prominent draining veins with kind of more punctate centrally. The hallmarks of arterial venous malformation. You need an enlarged artery, you need draining veins, and you need something malformed within the lesion itself. So here we have increased flow going to the region of the torcula, superior sagittal sinus. Here, and we can compare and contrast, right? So posterior inferior cerebellar artery, and look at it on the other side. It's gigantic, it's enlarged, and all of these draining vessels as well. So this is giving us, just as one sequence, is giving us the diagnosis of what's going on. What's always important is to see, has this bled? Is there hemorrhage within this? In which case it becomes more immediately apparent. And obviously, this is a gradient echo sequence, and we know on gradient echo imaging, it accentuates susceptibility and hemorrhagic artifact. And we see extensive evidence of prior hemorrhage within this on the surface of the cerebellum. So maybe there was subarachnoid blood that was present as well, counting for the hemorrhage, as a sequel of hemorrhage. So this, I think, confirming and substantiating the diagnosis of, this cerebellar AVM with evidence of prior hemorrhage. So the question here, I think it becomes very obvious that we absolutely needed the high field examination.
Thanks, Eddie. But again, I would think, the hyperfine or the low field would add on, especially if you wanted to do serial imaging. And as long as the child doesn't need any sedation and it's easy to perform on the bedside or in the room where he was sleeping, with his mother, it's not a big hassle. Okay, thank you very much.
Okay, I think we can open it up to a couple of more generic questions. Steve, have you been looking at the questions? And maybe I'll stop sharing my screen so that we can kind of see each other.
Would MRA have helped there? Because I guess it's something we're shooting for in the future on the swoop systems as well, Eddie.
So in my mind, when we talk about AVMs and whatnot, and talking about high field, people always say, oh, let's get an MRA, let's get an MRA. And it kind of confirms what you're seeing, but it's still not going to be sufficient. The child or patient is still going to require catheter-based angiography. So it would be helpful. I think if we had higher resolution on the T2, maybe more flow compensation, because we were able to make the definitive diagnosis you saw in the 3T2. We saw the increased arterial structures, we saw kind of the malformation and the draining veins itself. So MRA would, think of it like kind of a roadmap. It'll say, yes, there's something abnormal here. You're still it's not going to obviate the need for catheter-based angiography.
Thank you. Just another comment generally while we're waiting for one or two quick questions. We are building a sort of models where you can generate a volumetric scan from the ultra-low field from only one or two orientations. So we're, in some of the cases where that third axis, there was too much motion blurring in the coronal plane, then we might just use the other two orientations and reconstruct from that and provide you with something that gives greater conspicuity and doesn't sort of almost detract or distract you from a diagnosis. But that's something that's definitely in the pipeline for our Unity collaboration.
And I'll also add to that, on the hyperfine side, we also are working on and have the ability for isotropic imaging. So as we know, all of our imaging sequences are anisotropic. So they're not equal in every dimension. So if you reconstruct it, you're going to lose resolution. But it will be coming down the road, not available currently, isotropic imaging at a slightly lower resolution than the conventional, but gives you the ability to do that multiplanar reformat and do one sequence and get from that sagittal, axial, and coronal. In fact, it's been used experimentally here in the United States to provide some form of neurosurgical stereotactic guidance for biopsy with sufficient result.
And it's going to be used at 2 mil isotropic for our
Correct.
HIE trials with the caffeine challenge across many continents in the coming months. So we have one quick question from Abraham before we have to wrap up. How long does each sequence take on the low field DWI T1 and T2? I'll let you answer that, Eddie, but it's getting shorter. But I'll let
It's
you.
getting shorter. The way I like to look at it, if we do a routine brain, so sagittal, axial T1, T2, flare, and DWI, current software, about 22 minutes. The diffusion is approximately 8 minutes, flare about the same, T2 fast, 2.5 minutes, T1's anywhere from 3 to 4 minutes. And the beauty of this, and we've seen through these cases, and what Dr. Sabir selected is you can choose what you want to run. You don't have to run everything. You just want to get sufficient information to answer your clinical question. So you tailor it to whatever that question is.
And McLean saying that sometimes you have a large head and we sometimes squeeze people in. Well, McLean, the good news and the bad news is Hyperfine, I've heard you. The bad news is going to be on the V2 that's in the picture behind Eddie.
That's behind me over here.
Yeah, and the idea there being that not only can we accommodate slightly larger heads, but you could imagine a situation where we integrate other peripheral devices such as an EEG cap in the same session. Of course, so that additional space all helps.
So that the head coil on the second generation system is larger. In addition, just another point to make, there's increased signal to noise and clearing in the inferior posterior fossa. There's a new coil element that's being used. So there's increased coverage as well.
Right. And Marielle has just asked, how far should the head be positioned into the scanner to minimize artifacts? If the head is touching all the way back, but resting on the cushion, will we be okay? Or do you think we might have some artifacts?
I think the key is to get the head off of the coil itself. So in as far as possible, and resting on the cushion itself is essential. You need to realize that because of the inhomogeneous nature of the magnet itself, the sweet spot is purely isocenter, dead center in the coil. In an adult, so any of our heads, that's kind of obvious. A little child, you need to elevate significantly, and I'm sure Dr. Sabir can comment on this with the neonates, in the center of the coil in order to have more uniformity and increase signal to noise.
Thank you, Eddie. We are over time, but we'll just have one. Is there any plans with our infant spine? We many children are there. Ooh, well, I'll let you answer that one, Eddie.
So right now, our coil design and coil studies are involving the head and brain only imaging at that point in time. I have seen examples from some of our clinical sites, especially in premature infants and neonates, where you can see more of the body. I typically show a case where it's a post-cardiac surgical neonate premature baby with intracranial ischemia, but we can see pleural effusions because most of the chest is in that field. But that's not quite on our roadmap right now.
And John, with the V2 design is open at the back, and you could imagine more of the body, including thoracic imaging, might be potential in the future.
Again, I think that would require a different coil design.
Of course, exactly. Different coil
American
configuration.
football helmet design is not going to kind of work.
Can we use soup system with a stereotactic frame?
So in an adult, we've tried. I've tried with Lexel and some other forms, and it won't fit. And that was with the V1 platform. With the V2, possibly, I'm not sure. Clearly, frameless stereotaxy with fiducial markers, not a problem at all, especially useful as we go down the road to more isotropic imaging. And that imaging can be done in a stereotactic fashion and incorporated into neuronavigation systems.
Thank you, guys. I just want to wrap up and say thank you, Eddie, and the Hyperfine team. Sabir and Anna and Hemant from Bonn, you guys are such superstars. To be able to present cases from 5 weeks old to 17 years old was really, really very much appreciated. Collective Minds colleagues and Jess, who's championing the training and education for the wider Unity family. This has been a super professional, but also incredibly educational and informative session. Jess will be championing and bringing more of these to you and leading on this for many years to come in her new role as part of the Unity Education and Training Lead. And please, if you have ideas and thoughts for potential presentations, then email Jess. And thanks, everyone. Jess, do you want to say any final words before we wrap up?
Thank you so much, Steve. I just want to say a huge thank you to Dr. Knapp and Prof. Sabir for leading the session today. As Steve said, it was highly educational, and it's really nice to see clinical cases across such a huge age range and to have that comparison on high field and low field. And then, as Steve said, a huge thank you to Sabia and Anne, who sent through all the cases and shared all that background information so that we could put together some slides on with clinical context for each of the cases that were reviewed. So thank you to everybody, to Collective Minds, who were part of putting it together, and I hope everybody enjoyed it. Looking forward to the next one.
Absolutely. Thank you, everyone.
Onwards and upwards. All the best, guys.
Thanks.
Take care.
Bye.
Thank you so much. Bye-bye.